Hello and welcome to Speaking Week, and this session focusing on doctors. If you are joining this session and are not a doctor, then you might want to come back tomorrow or Friday if you are an allied health professional, or if you're a nurse, you can now view the nursing replay link of yesterday's session, which has been emailed to all registrants. All of the webinars are being recorded so that you can watch again whenever you want, or if you're unable to stay for the whole session. And hello to those tuning in on Facebook. Make sure you register via the link provided to continue watching today's session. And if any of you are having any difficulties connecting or with your sound or the vision, then please make sure you're using the Chrome browser to attend the webinar, and perhaps disconnect and join us again if you are having any difficulties. So in today's session, I'm going to share a brand new roll card with you, which will also be uploaded to the sample test section of the OET website soon. I'm also going to share examples of candidates completing the role play with me from around the world. So in the last 2 weeks, I have recorded role plays with 30 candidates from among the more than 5,000 who expressed interest in doing this. It would have been amazing to speak to even more candidates, and I'm sorry if you weren't one of those chosen, but I'm going to use scripts from the role plays I did record to demonstrate different strengths and weaknesses against the assessment criteria OET assessors use to mark your speaking test. Let's start with a couple of poll questions though. So this first poll question that's coming up on your screen now is to find out which of the free official OET resources about speaking have you used? So have you used our speaking masterclass? Have you looked on our YouTube page at the sample speaking test we have there with some feedback? Have you looked at the medicine video on how to approach speaking sample test 3? Let me know which of those resources you have already made use of. I'm sorry, I can see there's a typo in the first poll question. So that should say the medicine video on the approach to speaking sample test 3. I haven't changed the poll since yesterday, but I can see from those of you answering the question that around half of you have used our speaking masterclass, and others have used the speaking sample test with feedback, which you can see on our YouTube page. So if you haven't used those resources already, do head over to our preparation portal, our prepare page, and you will find all 3 of those things I've just mentioned: the sample test, including the video on the medicine sample test 3, how to approach that roll card, the masterclass on speaking, and the medicine sample test that's on our YouTube page. All right, so next question. This time I want to know, how often do you practice patient conversations? So let me know which of those options. Are you someone who is practicing speaking to patients and having patient conversations every day? Or are you someone on the other end of the scale who doesn't have anyone to practice this with? All right, so that's fairly roughly split. The majority of you, but it's only 40%, are saying that you do speak in English very regularly, but not with this kind of patient conversations. If you are working with patients in English, then you're really lucky in having multiple practice opportunities. But even if you don't, there are still ways that you can practice conversations with patients, which just requires a little bit of time from colleagues, family, or friends. And in the video that I mentioned on the last slide for speaking sample test 3, I explain how you can do this even without having a new roll card to practice with. All right, so we have one more question. The third question is about the assessment criteria. So this one's asking you, how confident do you feel about the speaking assessment criteria? Is this something that you already make use of very regularly as part of your preparation? Or are you someone, and don't feel embarrassed if this is the case, it's just good for us to know, are you someone who hasn't seen the criteria, not really sure what it is the assessors are looking for when they're marking your speaking? All right, as I would expect, the majority of you, 62%, are saying, I have a general idea about the speaking criteria. And these criteria are so important. They're on the screen now. They're so important to your success on test day. After all, this is a language test, and you're only going to score the grade that you want if you evidence each of the criteria to a high level. So if you're not sure what the criteria are or what the assessors are looking for, this is something that you need to fix fast. This session is going to be a really good start. But make sure you download the criteria from our website link that I've got on the screen there. Save them to your favorites or print them off and stick them on your wall, ideally with the writing assessment criteria as well, because in the same way that these criteria are really important to helping you score well on the speaking test, the writing assessment criteria are exactly the same for the writing test. So to score a B grade in your speaking test, which is the score most of you are aiming at, you need to score mostly 5s from the linguistic criteria you can see on the left, and 2, which is a competent user, for the clinical communication criteria. And I'm going to look at each of these in more detail at this level of where you need to be getting a B grade, to make sure we're clear about what this means for your speaking performance. So the first of the criteria is intelligibility, which means your speech is easily understood with what is called minimal strain for the listener. And my best way of explaining strain is the expression on that emoji on the screen, a quite puzzled, confused kind of look. But the patient or interlocutor might not always show this strain on their face. It is, after all, a little bit impolite. So instead, internally, their mind will be turning, trying to understand what you have said. Another indicator that there is strain is if the interlocutor doesn't answer the question as you expect. Perhaps they just say, yes. This is something we do in English when we know we've been asked a question, but we haven't understood it, and we don't like to ask what you meant. Another part of this criteria is your accent. And while it's fine, absolutely fine to have an accent and to make some pronunciation mistakes, a heavy accent or significant pronunciation errors, that was a good word to slip up on, for the task would reduce your score here. So let's look at an example from one of the medicine role plays. So with this doctor's speech, although you can't hear it, the pronunciation of some of the words when he was pronouncing them were a little difficult. For example, the way that he pronounced fluid and the way that he pronounced well when he was saying well hydrated. And this with the repeated words near the start of his response. So he says after, I, did cause a little bit of strain for the interlocutor. So that would impact the score for intelligibility. If we look at fluency, so to get a B grade for fluency, it means you need to be fluent at normal speed, and any hesitation you do make is due to the natural process of thinking and speaking at the same time. So you may occasionally repeat yourself or self-correct what you've just said, but the amount of this wouldn't confuse the patient. And the words normal speed are important here. This speed could be different depending on what you were discussing with the patient. So imagine explaining a process to a patient or giving them results of a test. Would you talk about these at the same speed as you would when asking them questions or answering a routine question that they have asked you? No. So you need to make sure your speed is appropriate for the content that you are giving them. So let's look at an example of this. So often with fluency, we see candidates being so fluent that they don't pause enough to involve the patient or carer sufficiently, or perhaps they're trying to cover too many details without stopping. So that has its own problems, but this doctor had the opposite problem of really only giving quite short answers, and so not demonstrating the fluency that he actually had. And this is an interesting point to focus on. So for OET purposes, even if you are still a medical student or trainee like this doctor, for OET purposes, you are a fully qualified doctor. We don't know in your application which part of your process you are at. So for our purposes, you are a doctor. You don't have to give medically accurate information, but you should speak as if you were a qualified doctor already. So this doctor, although not certain about the accurate amount to answer the parents' questions, could simply have made it up, or the second part of his answer, pretty much as often as possible, would have been perfect by itself. Looking at appropriateness of language. So this is assessing you on your level of formality, your tone of voice, and the vocabulary that you use, which need to be mostly appropriate for the scenario you are discussing. Formality may be different depending on whether you have met this patient before, according to the background information, the age of the patient, or their healthcare needs. Similarly, you use different tone of voice when you are showing empathy or reassurance to when you have to firmly advise the patient to do something. Your vocabulary choices are also linked to the function of what you are discussing. So whether you are advising, asking questions, or reassuring. Occasional mistakes in these areas are okay, but overall, you do need to match these three things well to the role play that you are participating in. So in this example, the explanation is fairly clear to understand, but you could say this doctor is being a little bit formal for the situation, and some of the vocabulary choices could have been changed to be a little bit more appropriate to the situation of talking to a parent about their young child. So that's language in the middle saying object which had already been contaminated, maybe with vomit or feces or something like this. That phrase, that long phrase, could have been changed perhaps to be slightly less formal, but also perhaps more personalized to the parent that they're actually talking to during this situation. And resources of grammar and expression. So in this criteria, you are showing the assessors that you can be flexible with English, that you have the grammar and vocabulary necessary for this situation and to respond to the patient. So this means demonstrating different tenses, conditional forms, phrasal verbs, perhaps occasional colloquial or idiomatic phrases. But don't think of them as a tick list that you can simply tick off when you have used them once per role play. Instead, like the images on the screen, they're like a filing cabinet. You pull them out when they're needed and as many times as they're needed. Occasional mistakes are okay, but in general, they shouldn't prevent your meaning from being clear or the conversation from continuing smoothly. So in the example that we have here, the grammar in this doctor's speech isn't perfect, but it is very clear to understand the meaning, and the doctor is demonstrating a range of forms and appropriate phrases for this situation, such as, "It's really hard seeing your child suffering." So this is a good example. Your grammar and expression doesn't have to be perfect to score a B grade, but it should show variety, flexibility, and suitability to the situation. So let's look now at the clinical communication criteria. So there's quite a bit of misunderstanding about these. Compared to other English tests, these are not criteria you will have been tested on before. So you are obviously used to demonstrating all of the previous 4 linguistic criteria we looked at, even before you reached testing standard while you're learning English at school, for example. But not being familiar with these clinical communication criteria is no excuse. They aren't weighted as highly as the linguistic criteria, so these are scored out of 3, while the linguistic criteria are scored out of 7. But there are 5 clinical communication criteria, and it's pointless to throw away scores. Another misunderstanding is that candidates think they are assessing your medical knowledge, probably because of the word clinical in the title. However, this isn't true. They are communication criteria in the clinical context, or in other words, important communication skills which healthcare providers need, which are separate to the actual medicine that they're discussing. We're going to go through them one by one, so hopefully you'll be able to see what I mean. So the first of the clinical communication criteria is relationship building. And the ways that you can evidence this criteria are by starting the role play appropriately, using introductions where they're needed, or perhaps a greeting, and maybe establishing the purpose of the conversation. You also need to show respect for the patient and their situation and not judge their opinions or attitude towards their health, even if part of your task will be to try to change this attitude during the role play. Showing empathy for the situation the patient describes or what they tell you, both in the words that you say and in the tone of voice you use in your responses, is also important. And collectively, these approaches to the conversation help the patient feel like you are on their side, that you understand them, and that you will work with them as a team to address their health needs as best you can. So in this example, the doctor was very good at showing empathy for the parent's situation. So they use a couple of different phrases in their response. Your son will be okay. This is a condition not to be overwhelmed about. Don't be worried. So again, although the grammar isn't perfect, the empathy is coming across very clearly in their response to the parent's situation. Understanding and incorporating the patient's perspective. So this means asking the patient to tell you about what is worrying them or what they feel comfortable to do. Or if they tell you this information without you needing to ask, asking follow-up questions to make sure you fully understand, or respond in a way to show you have listened by including some of what they say in your response. Perhaps it could also be used later on in the conversation when you are providing an explanation. It also means, though, noticing how the patient answers your questions or tells you information. Do they use language to show they feel uncomfortable, anxious, or embarrassed? Or perhaps do they use words that sound like they agree, but from the tone of their voice show that they don't really? So, for example, maybe, or I suppose so. In this example, the doctor demonstrates he was listening to the parent by including what the parent told him in his response. So the doctor says, you had a rough day and a half and are hesitant to go home. He puts the parent's explanation of their concerns into his own words, but still is repeating the gist of what the parent has told him. So it's a good demonstration of incorporating the parent's perspective in his response. Providing structure. So this means taking responsibility for the conversation and the content that you want to discuss with the patient or carer. And there are a number of different ways that you can do this, including signposting that one discussion point has finished and a new one is started by naming the new point you're about to start talking about, or checking if the patient requires any clarification before introducing a new point, or simply by making a clear pause and intake of breath to show a change of direction. Other organization techniques include offering a summary of a process or what has been agreed, or things like adding intensifying language such as really important or essential that you do this, which help the patient to understand which is more important from the less important information or advice that you may be giving them. In this example, the doctor is offering a summary of the situation so far before proceeding to give an explanation of the current position. So they say, to recap what just happened. This introduces their summary. And this is a good point to pick up on. A summary can be within the role play, within the conversation. It doesn't just have to be at the end when you're summarizing what you have agreed during the conversation. All right, information gathering. So the skills in this criteria are all about assisting the patient or carer to be part of the conversation. It may seem a little counterintuitive in a speaking test that you should be encouraging the patient to talk more, but it is important that there should be a balance. It's rare when we are speaking to another person that we do all the speaking and they do all the listening. In real life, and certainly with patients, speaking is a two-person process, and we can complete the conversation more effectively if the other person is actively involved in it. So to do this, you need to give the patient opportunities to speak by asking open questions first, so that they tell you the situation in their own words, before clarifying what they've told you using closed questions. When they are speaking, show that you are listening by not interrupting, but providing encouragement through sounds like, right, and then responding using some of what they told you, or by giving a summary of what you have understood. It means making sure you have understood what they said by asking for clarification when it's unclear, or, as we looked at before, when their words suggest one thing, but their tone means another. Finally, it means avoiding asking compound questions, which in other words means 2 or 3 questions in one go. So an example of that would be, can you tell me about how long you've had these symptoms, how severe they are, and any medications you've tried? That's a compound question, and the patient or carer doesn't really know which of those questions you've just asked to start with. And it may be that they answer 1 or 2 of them, but they miss out another and you end up having to repeat the same question. So it's much better to ask 1 question at a time. The other type of question you should avoid are what we call leading questions, which are the ones which suggest the answer to the patient rather than letting them answer it in their own way. So, for example, the pain has got worse recently, right? You're really leading them to say yes there because you're putting the words into their mouth. So in this example, the doctor starts with an open question, what's the problem with Stephen? And then gets more detail by asking closed questions. So what are the symptoms that brought him to the ER? And then clarifying his understanding as the doctor with a final question to check he's understood the parent's anxiety correctly. The last of the clinical communication criteria is information giving. So by contrast to information gathering, this is about how you speak and provide information in those parts of the conversation where you need to do this, when explaining options, giving advice, but it's still focusing on how you include the patient in these sections. So, for example, by finding out how much the patient knows already about the topic, so you're not giving them unnecessary information, checking they've understood and that you have provided sufficient detail for them to feel clear about the situation, or perhaps asking them explicitly if they feel comfortable with what you have said, and if not, to feel safe to share their concerns. Pausing is important here. You must remember that the situation you're discussing with the patient is likely to be the first time they've heard it. And if you rush through everything, they will miss important details or just end up feeling worried and confused. Watch their face. This is a good indicator of whether they are relaxed because they are following what you are saying, or feeling stressed because you are providing the information too quickly. So in this example, the doctor mentions that they will provide an explanation and then pauses. The parent responds with okay. And then the doctor follows on by checking if they are happy with them providing that information. So now we've gone through each of the assessment criteria with some examples. I want to share with you 5 top tips that came out of completing the role plays with the 30 candidates in the last couple of weeks. So the first tip is how you start the conversation is really important. If you're not clear about who you're talking to or who the person's name is, ask this during the preparation time and read the background information carefully for clues. The second tip is not to rush. So the conversation is much more important than completing all of the tasks. After all, this is supposed to be a patient, and they need to understand and be included in the decision-making process that you're describing. Tip 3, and we'll look at some examples of these in the second half of the webinar. The information provided in brackets on the roll card is optional. And if you do decide to use it, you may need to alter the language from within the brackets or think about how and when to say it to keep the patient feeling comfortable. The information in brackets is provided in technical language suitable for doctors. And so the potential is that you will need to change it to be more accessible or suitable for the person that you're talking to. Task 4 is to not add to the tasks on your roll card. And this may go against some of the healthcare training that you've completed as a doctor. So, for example, in your training, you may always take a complete history or ask additional questions. But if it's not part of the card to take a complete history, or the questions that you're asking are not to do with one of the tasks, you shouldn't do that for the purposes of OET. You only need to do the tasks that are provided on the card. And the final top tip is, if you are using healthcare terminology, make sure you explain it to the patient or check that they are familiar with it, and use lay language wherever possible. So let's have a look now at the new medicine role play card, and I'm going to pick out some of the details together for you. So here you can see I've highlighted that the setting is the emergency department, and the background information tells us that the parent you were speaking to brought their 4-year-old son to the emergency department 2 hours ago after he had been vomiting for the previous 36 hours. The boy was diagnosed with viral gastroenteritis, and he has been given oral rehydration fluids. You've just told the parent that it's safe to discharge their son, but the parent seems anxious. And there are 5 tasks on the card. Find out about the parent's concerns, explain viral gastroenteritis, give information about how gastroenteritis is spread, resist the request to keep the patient in hospital and advise on hydration and appropriate clear fluids, and convince the parent that it is safe to take his or her son home and advise when to seek medical advice. So you can see, as I've just explained about the brackets, I've only highlighted the actual tasks. The information provided in brackets is optional. It's there to help you to provide the explanation if you're not sure what a definition of viral gastroenteritis is, or some ideas about how you could explain how the condition is spread. But it is provided in technical medical language. And so, as I previously explained, it is a good idea to change that into your own words to make it suitable for the person that you're talking to. So we're going to go through the tasks one by one and look at some examples from the different role plays I recorded to see where there were some strengths and weaknesses among the different doctors. A few of the doctors were more successful than others in making use of the background information to start the role play. It's clear from the card, as I've just mentioned, that the role play is part of a continuing conversation with this parent. The background information says, "You have just told the parent it is safe to discharge him." Let's look at some of the less successful examples first. Actually, before I do that, I just want to pick up on these doctors made good use of their preparation time to ask the name that should be used. So these doctors recognized that they had been speaking to this parent before. And so the doctor on the left checked what name they could use for the parent, and the doctor on the right also checked the name to use for the parent, but also the name to use for the patient, for the parent's son. So that's excellent use of the preparation time and meant that those doctors were able to start straight in with the conversation. But the doctors that didn't do it quite so successfully, you can see on this screen that the first doctor on the left starts off by saying, "What can I do for you?" Which isn't particularly appropriate to this background information. And the doctor on the right also is asking about the patient's name and what is the problem with Stephen. So both of those doctors haven't really picked up on that phrase that you've just told the parent it's safe to discharge him. Of the other doctors, I'm going to show you 3 examples on the screen. I want you to tell me in the chat box which way of starting the role play do you think was best and why. So do you think number 1, number 2, or number 3 was the best way to start this role play? And maybe just a very brief explanation why you thought that would be best. So do you think 1, 2, or 3 is the better way to start the role play? The first 3 answers say 1, 2, and 3. Then we're getting some more for 2s and 3s. Does anyone want to say why you think those ones are better? I think the majority of you are saying 2 or 3. I would say that none of the candidates really used the background information that effectively, but they had all picked up that the son was ready for discharge and that the parent was feeling anxious about it. So they're all sort of a similar degree of strength. They could still be better. But they have at least picked up this fact about the son being ready to go home, and they make use of that when they respond and ask the parent how they're feeling about it. So the second task was to explain gastroenteritis, and it was clear that the candidates felt very comfortable to do this, either from first-hand experience or because they had those prompts in brackets to help them. But some candidates were better at using language which was clear and at an appropriate lay level for the parents. So the doctor on the left, Ben, in his explanation of viral gastroenteritis, made use of things that the parent would be very familiar with, for example, the common cold. So he said, similar to the common cold, except instead of affecting your throat and nose, it affects your gastrointestinal system. So that's something very clear that the parent could understand. Whereas Navsin, the doctor on the right, brings the explanation back to the parent's son several times by saying, in your son's case, why he's suffering and he's having the stomach pain. So they've both done it quite differently, but the one on the left uses lay language very effectively. The one on the right makes it very relevant to the parent. So they've both done a good job in their explanation. Compare these to 2 other doctors and their explanations. They're also not bad, but they're not quite so clear or parent-centered. So The doctor on the left, Ahmed, is generally okay, but he does include diarrhea in his explanation, which isn't one of the child's symptoms. So if you could imagine saying that in real life to a parent, the parent might be thinking, oh, he hasn't had diarrhea. Is he going to start having diarrhea? Or does he know this is my son? Maybe he's thinking about another patient. So that's a little slip, I would say, for the doctor on the left. The doctor on the right, as we looked at before with appropriateness, this is a little bit formal. It's talking in the abstract of a child might do this, or you need to do this for the household, rather than relating it to the actual parent or child which is in front of them, which the doctor on the previous slide managed so much better. Task 3 required the candidate to say no to the parent's request that their son stay in hospital. So the strength here was that all candidates did this tactfully and with empathy. So obviously saying no to a patient or a parent isn't the easiest thing to do. And if you want to have a successful conversation, you need to do it with respect and with tact. So some good examples that you can see here. The first doctor on the left mentions that this is a natural concern and also brings in his own experience. He says, I truly understand that from a parent point of view. I'm also a dad. And that's certainly something that you can do if you have some of your own experience which is relevant to the situation that you're discussing. The doctor on the right also says something similar. Really, I appreciate your concern. It is usual concern of all parents. So they validate the parents' concerns before they go into resisting that request and explaining why the son can go home. And the last example, the doctor again is saying, I can understand why you're worried, but then sort of goes further and says, we're very confident this is a viral syndrome and it's something that a lot of people get and successfully treated with. So again, validating the concerns while also reassuring them that it is safe for them to take the boy home. One of the doctors went a bit further with their explanation about why the son shouldn't stay in hospital. So they mentioned that there are some risks actually to staying in hospital because of other infections and his immunity is reduced. What this doctor said was correct, but perhaps it was more than necessary for the parent as the first explanation, because you don't want to scare the parent into taking their child home. You just need to explain, as the doctors did on the previous slide, that you understand why they're worried, but that they'll be fine at home. You are very confident that what they have is something that can be treated well at home. This extra detail that this doctor provided straight away at the beginning could be useful later in the role play, where the last task is to convince the parent it's safe to take his or her son home. So this would be a useful argument to convince the parent if they remain reluctant that it is safe to go home. The second part of task 4 was to advise the parent on hydration and appropriate clear fluid. So again, I'd like to hear from you in the chat box. Which of these 4 examples do you think was most successful at advising how to keep the son hydrated and what were the appropriate clear fluids? So let me know the one that you think is the best and why. So what do you think the doctor that you think was most successful did well? Okay. So why do you think, if you think it's 3 or 4, what do you think was more successful about that option, if that was the one you think was the best one? Got a lot coming through for 3. All right, no one's being brave enough to explain why they think it's better, but I'll just mention a couple of points about all of them. So number 1, this section wasn't 100% fluent, and the repetition of words and additions of reduce the clarity for the parent. So I wouldn't say number 1 was the best option here. Number 2 also lacked some clarity by mixing the type of fluid to give with the reasons for giving the fluid and then returning again to the type of fluid to give. And it also included some quite technical language that perhaps the parent wouldn't have been so familiar with. Number 3 would have been a bit clearer without the statement about hospital in between. The doctor did repeat it before and after that statement, so it wasn't as bad as it might have been. And there's also no mention of unsweetened with the fruit juices, which is something mentioned on the roll card, which I believe would be an important point here. Number 4 was clear and concise. And this one, I would say, is most successful. Why to give the fluids and what type of fluids, and particularly what type of fluids was, it was quite short, but at the same time it was also very clear. What I will pick out from all of the doctors is that they made use of gastrolite, which was provided as information in brackets with the task. And as I've mentioned a couple of times now, you're very welcome to use the language provided in brackets, but just make sure that you consider, is this something that the person you're talking to will be familiar with? Personally speaking, I'm not really aware of gastrolite, what it is or what it's for. And it would have been good to see at least one of the doctors explain this to me as the parent when explaining that it was a fluid option for the task. For the final task, which was to convince the parent that it's safe to take his or her son home and to advise when to seek medical advice, not all of the candidates had enough time to cover this. This is okay if the previous 4 tasks have taken up all the time and you've been responding well to the parent's concerns. But if you have spent time at the beginning of the conversation, for example, asking your own questions or things that weren't part of the roll card, that's less good. So you do need to plan your time and stick to what you need to discuss on the card. So have a look. I'm going to show you 4 examples of the candidates completing task 5. And this time I want you to say left or right. Do you think the left example is more effective or the right example? And again, if you feel brave to do so, let me know why you think that would be true. Okay, so we've got a few people suggesting the right hand side doctor was more successful. Shoaib says the doctor on the left was repeating words. And Kurat says the left one, it lacks explanation of the red flags. Yeah, I would agree with you. So the doctor on the left was quite effective about convincing the parent. They were using reassuring words and also certainty. You know, I will give you some instructions. I'm sure he won't develop any complications. And he mentioned some red flags, which is when to seek medical advice, but he didn't say what those were. Now, this could have been that because after he says, okay, that was the end of the role play. The time limit was up. The 5 minutes was over. And maybe he was going on to say what those red flags were after that. But, you know, just mentioning red flags and then not saying an example, at least one example of what those were, I think was a missed opportunity there. The doctor on the right-hand side gave very clear examples of when the parent should seek medical advice, including what I thought was a really good explanation of skin turgor. He didn't assume that as a parent I would know what that was, and it was a very simple test that I would have been able to replicate myself as the parent for my son. Also, a little bit later, he was quite firm and confident in his response, which would have convinced the parent to go home with her son. Let's look at 2 more examples. So again, let me know, do you think the doctor on the left or the doctor on the right was more successful about convincing the parent and advising when to seek medical treatment? Great reading your comments. Many of you are repeating the sort of bits that I just picked up on those previous doctors. What do you think of Dinesh and Swad? So this time, doctors are suggesting the doctor on the left. What do you think is better about the doctor on the left? Edward picks up, you should never say I'm 100% sure, which is, I'm sure, correct medically speaking. You wouldn't be penalized for that in OET because, as I mentioned earlier, you're not being tested on your medical accuracy. But I can appreciate as a doctor, you might feel like that was a mistake. So Farhan is saying the left explained the red flags and gave reassuring. Afolabi said it was convincing on the left. Dozy says that the left is better because of the explanation and reassurance. So yes, I agree that the doctor on the left explained the red flags of when to seek medical advice. And what I thought he did well was provided them in a way that was appropriate to the situation. So, for example, he said, if he's not playing well. So that's obviously a really clear indicator to the parent of something that their 4-year-old may not be doing, and then would trigger them to think they need more medical advice. And again, he used his experience as a dad to convince the parent it was safe to go home. Now, I wouldn't encourage you to do that every time. But if it is appropriate to your situation and to the situation that you're discussing, it is certainly something that you can do for the role play. The doctor on the right also mentioned a couple of reasons when medical treatment should be sought and provided more reassurance about the parent going home. So this was okay, but as some of you picked out, perhaps not quite as fluent as the doctor on the left. So having looked at some real candidate responses to this role card, in summary, every candidate will have different strengths and weaknesses. So hopefully what you've seen by looking at examples from different doctors doing exactly the same task is that they all do it quite differently, and that's to be expected. Our personality is very important when we're speaking to people. And so the way that we talk, the expressions, the language that we use is quite personal. And so you don't need to imagine that there is a perfect way to complete the role play. And of course, the patient or carer that you're talking to is also different each time. And some patients and carers will find it much easier to understand what you're describing to them than others. And that would be true in real life. So what is most important in the role card and in the role play is that you evidence the criteria to the assessors. Looking at those assessment criteria, as I said at the start of this session, is really important to understanding what the assessors want to see and is a valuable part of your preparation. It's something that you should be making a regular part of your preparation, to look at those criteria and to make sure when you're listening perhaps to your own recording of a role play, how well you have evidenced them. As I've mentioned, it is a language test, so you're not being judged on the accuracy of the medical information you provide. And if you're not clear about something, it is fine to make it up, provided you are using good English to do that. You won't be penalised for lack of medical accuracy. And finally, to remind you that your assessment is from both role plays. So you have the opportunity, if there were some weaknesses in the first role play, to improve on those when completing the second role play, or vice versa. If you feel you didn't do such a good second role play but were really strong in the first one, then it is a balance. And so there is opportunity to balance out your score across the two role plays. So we have a little bit of time now, around about 8 minutes, for me to answer any questions that you might have about the speaking test as a doctor. And I'll just pick out a few of those to answer while we can in the little bit of time that we have left. All right. So yes, just to pick up on sort of some general points, the role card will be available on the OET website in our sample test section by the end of this week. And the recording from today's session will be emailed to you fairly promptly after this session finishes, I believe. So you'll be able to click on the link and watch it again if you would like to. Olalakin says, we have 2 role plays for the speaking test. Yes, you do. So today I've just looked at one of them. After completing this role play, you would then be given a new role card and complete the second role card straight away. Ramila says, is it necessary to introduce ourselves to a known patient? I think as we've looked at today, and what I was suggesting some of the doctors did very well, they could see that they've already introduced themselves to this parent prior to this role card situation taking place. And so there was no need for them to introduce themselves again. Rather, they just greeted me as the parent by name. And that was a very successful way of demonstrating to the assessor that they'd picked up the information from the background information on the card. Pierre says, can we look at the card during the test? Absolutely. You have the card throughout the test. Daniela says, should the patient be interrupted to provide structure? So I would be very cautious about interrupting the patient at any point during the role play, because obviously you need to allow the patient their opportunity to explain the situation in their own words. Now, obviously, if they're giving very long responses to every question that you ask them, you may need to eventually sort of cut in and say, you know, thank you, this is all really good information. I now want to ask you something else. But in general, and I feel it's quite unlikely, you should avoid interrupting the patient when they are speaking. Renee says, is there a list of scenarios that will be chosen from that we can use to practice? There isn't a set list of scenarios, Renee. What we say about the speaking test is that they will be the type of typical situation, as you saw today, that you would expect to meet as a GP or perhaps an emergency doctor on a very day-to-day basis. So nothing unusual, nothing breaking, cutting edge, something like that. Very sort of standard situations that you would no doubt have studied in your medical training at some point or other. Patricia says, can I make up the name of the patient if I don't ask the interlocutor? Yes, that is certainly an option that you can do as well. So if you want to start by greeting the patient, you can make up a name for them. Or during the preparation time, as we saw in the examples today, you can ask them for those for their name that you can use. Emily says, do I need to make eye contact with the interlocutor because my conversation will be recorded for assessment? So there's no assessment requirement that you make eye contact with the interlocutor. All that is recorded is the audio, so the speech, and the assessor listens to the audio when they are assessing your speaking. However, what we do say is we encourage you to try and believe this is a real life patient, a real life situation. And so obviously when we're talking in real life to people, we do make occasional, if not frequent, eye contact with them. And that sort of helps us to create a connection with them and to sort of believe that what we're talking about is real. So I would encourage you to make eye contact for that reason, but it's certainly not assessed. So you don't need to worry about making eye contact a certain number of times. Kaku says the topics for the role plays are medical. So yes, if you are a doctor, then you will have role plays that are suitable for doctors, for medicine type situations. If your profession is not medicine, for example, you're a nurse, you're a dentist, you're a physiotherapist, then you will have a role card which is suitable to that profession. And tomorrow and Friday, I will be doing 2 further webinars which touch on some of those allied health professions. So you're welcome to join me if that is your profession. Beanish says, in the 3 minutes, can we ask the interlocutor regarding the patient's name? Absolutely, and I showed that a little bit earlier in this webinar session, how a couple of the doctors did exactly that during their preparation time. Sharon says, is it appropriate to use our hands to demonstrate certain symptoms? So, for example, pinching of the skin. Absolutely, I would say that's appropriate. However, it's a little bit like making the eye contact. So if we go back to that example that the doctor gave about skin turgor, and he mentioned about pinching the skin, you could certainly demonstrate it, but you also need to verbalize it because the assessors can't see you pinching your skin. They can only hear what you're saying. So absolutely, as you would in real life, feel free to use your hands for gestures or explanations, but just make sure that you're also verbalizing it as well. All right, so I'm just going to pick for 2 more questions and then we'll have to wrap up today's session. Dennis says, I have a heavy accent. Should I be worried about the speaking section? So as I mentioned during the intelligibility criteria right at the start of this webinar, it's absolutely fine to have an accent. We don't expect you to remove all traces of your accent from your speaking for OET. It's lovely to have accents from around the world taking part, and it makes life so much more enjoyable to have accents. The difficulty is, and where it might impact your score for intelligibility, is if the interlocutor is struggling to understand you because of your accent. So if they're giving that confused face or they're asking you to repeat yourself many times, that could be an issue. So that's a good way to test the scenario. If when you practice with a friend or a colleague, they have that trouble to understand your accent, then it may be that you do need to do some remedial work on your accent. But otherwise, a fairly standard accent from any part of the world is not penalised at all. And then let's look for one last question today. Ramilla says, are we penalised if we cross 5 minutes? So my experience when I was recording these candidate conversations in the last couple of weeks was I sometimes found it quite difficult to stop the conversation exactly on 5 minutes. But I believe the interlocutors are trained to be really strict about that. And so what will happen is once you reach the 5 minutes, they'll perhaps give you an extra 10 or 20 seconds to try to see if you're about to finish what you're saying. And if not, they will interrupt you and they'll say, thank you, that's the end of the role play. So you're not penalized, you are told when to stop. And our advice is really that you just keep speaking until the interlocutor does tell you that the time is over. All right, thank you so much for joining me today. I hope you found the session useful. As I mentioned, the recordings from yesterday's session for nurses and today's session for doctors will be emailed to you, so you can watch this session again. If you're one of our allied health professionals, then do join me either tomorrow or Friday for your profession, and I look forward to seeing you then. In the meantime, please take care, and I'll talk to you again soon. Bye for now.